Thank you very much. So I'd like to start thanking LFSA for all you've done in the last few years. You've been amazing, and it's really a big, big honor to be here speaking to you all. And I'd like to thank also David Malking for also all he has done to us and to the patients in the last few years. And I would like to start with this family that I've been following for the last 15 years. Our proband, the person who first came to me, was this lady at the age of 57. At that time, she had already had 3 primary tumors. The first one was diagnosed at the age of 51. She had sarcoma of the vena cava, which was quite an aggressive tumor. She was able to make it. She had a breast cancer, a ductal invasive breast cancer 2 years later. And after that, she had the thyroid cancer. And she was referred to a cancer genetics clinics, and she came with her children. And at that time, we talked about Li-Fraumeni Syndrome, and I asked her about her family members, and she told us, well, there's so many people in my family who had cancer, but they would never come here, so you would have to come to our place. So that was a time when Pierre Hainaut and Patricia Prola, who are here today and who will be speaking to you later, they came to São Paulo, and the 3 of us, we went on a field trip. We went to their hometown, and we were welcomed by the matriarch of the family, who had like a big reception for us in her kitchen. And she had almost 30 people from the family there at that time. And we had, for the first time, the amazing opportunity to talk to the patients, to that whole family, about Li-Fraumeni Syndrome. We didn't know anything about the tropero at that time, but it was quite interesting because at that time, she also told us about the grandfather. She had, well, I had a grandfather who used to leave town and only come back 6 months or even later on. And I don't know, maybe he was a tropero, maybe he was the one who put all the families around there. So what happened was that this family, we had this very atypical presentation, because it was after we had this meeting with the family, we had a second meeting. They called us and they said, well, I think more people from our families want to come. And would you be able to see them? And I said, yes, let's say 10 days. And then they came. They never told me how many people would come. I expected other 30, but actually 2 buses arrived. And the hospital wasn't prepared for that. So we opened the door and people just kept coming, and I wasn't prepared. So I called the nursing school. They all came. I called the psychologists. They all came. And we had a big auditorium like this one with all the family in that. And we were able to start really this huge pedigree. One of them was very interested, so he went and helped me with church registries, and we were able to get information up to the 1800s. So this was quite an amazing history of this family with an atypical presentation of Li-Fraumeni syndrome, because although they had typical Li-Fraumeni tumors, they were almost all of them at a later age. Sarcomas at a later age. We had also adrenocortical carcinomas, glioblastomas, central nervous system tumors. And we could clearly see that there were people who were carriers, like these ones. This gentleman, he passed away at the age of 101 years old. And he developed gastric cancer at the age of 100 years. So that was quite an interesting presentation for the syndrome. So this is Brazil. And this is the part of the country where we are seeing most of the families. When we came back of that hometown that we went with Pierre and Patricia, we stopped in a bookshop, and we started reading this history book on the troperos. And when we went back to the office, we tried to see all the families that we had diagnosed with Li-Fraumeni syndrome, and we overlapped them in the map, and it was amazing because it was exactly the same road as the Tropero road that you see here. So probably this gentleman really, who was in the back of a mule, stopped every 30 kilometers and disseminated this very frequent mutation in South Brazil. So what we did now with Patricia is to try to gather together all the Brazilian families who carry the R357H mutation. And we have another collaborator from Barretos, Edenir Palmeiro, a longtime collaborator. And now we're up to 152 families with Li-Fraumeni syndrome, with over 570 individuals with the same germline mutation. And they were all recruited in a cancer genetics clinics with genetic counseling. So all of them receive the same information as all of you receive when you get the genetic testing. And the profile of tumors was quite similar as the typical Li-Fraumeni. So here in the Li-Fraumeni syndrome, the core tumors, as you know, are sarcomas, central nervous system, breast cancer, and also adrenocortical carcinomas at an early age. If you overlap with the R357H, the tumors we find among our patients is very similar, but with this time difference, it's like a shift that we see, and probably due to modifiers that we have found in the course of our studies. So just to exemplify the São Paulo cohort, we had 58 families being followed with the R357H mutation. And what was interesting is that to see all of that, we saw all of them, and among those individuals who were found to carry the mutation, half of them had at least one cancer. Some of them had multiple cancers, and even one patient who unfortunately we lost 2 years ago had 19 primary tumors. She was a big fighter. Some of you knew her, and really here is my homage to her. And if we separate just the patients who had who were recruited before the age of 16, 24 out of the 37, so that means over 62% of those individuals had a cancer. 20 of those were adrenocortical carcinoma, but that wasn't it. They had also choroid plexus carcinomas, the central nervous system, rhabdomyosarcomas, and among those who had been diagnosed between the age of 15 and 60, 36 had at least one primary tumor. So clearly, this is a Li-Fraumeni syndrome mutation with a very, very broad spectrum of tumors, but that occur at a later age. So those individuals were included in a screening protocol that we had them do the Toronto protocol that included the whole body MRI as well. And among our patients, among our patients, we were able to detect 11% of them with a tumor. Most of the people who came to the clinic to do the Toronto protocol were asymptomatic. And we did a second round of whole body MRIs in those, and 4 of them were diagnosed with a malignancy at that time. And the good thing, there were no unnecessary procedures to those individuals. So that means we didn't have to do a biopsy where there wasn't a cancer. So if we put together all these information, in R357H carriers, the risk of a woman developing a breast cancer is 4-fold compared to the general Brazilian population. The risk of developing a soft tissue sarcoma, it's 24 times the risk of a general population. The risk of brain tumor, it's 8 times regarding what we see in the rest of the Brazilian population. And for adrenocortical carcinoma, it's 550 times. So it's really a major risk in those individuals. So we start screening those families. Whenever they have a baby, we offer testing for the families right away when the baby is born. And the best thing is to do a whole body MRI as soon as possible. We have thoroughly discussed this with David and with the radiologists here in Toronto. And they have this amazing technique where they wrap the baby. The mother breastfeeds the baby, the newborn. They wrap up the baby and they put it in the machine. So the baby doesn't need any kind of an anesthesia to do the whole body MRI, which is an amazing procedure. So if we talk about the penetrance of this mutant in the Brazilian population, the R357H mutant, if we separate the female from the male, this is a very high risk, lifetime risk mutation that we find, with an 80% lifetime risk in all women who carry the R37H mutation, and a moderate risk for men, 43%. This is mostly due to breast cancer, but also due to overrepresentation of leiomyosarcomas in women as well. And so I'm working both at the NIH in a Brazilian institution called Syrio and Lebanese. We're restarting the Brazilian cohort there. And 2 weeks before after I arrived, I was able to see this patient who had a breast cancer at the age of 47 and a lung cancer at the age of 56. And she came referring that her brother had passed away due to a glioblastoma at the age of 56. And her niece, who had a brain tumor, also at the age of 1. And she had other cases of brain cancer and other tumors within her family. And she got tested, and she carried the R37H mutation. What was amazing was that we were able, within 15 days, to get all her children tested, both her kids. They were both found to be carriers of the mutation. 2 weeks later, they came back with a newborn, 2 newborns. I told them about this possibility of doing the whole body MRI in newborns, so that they just got tested for those 2 kids who are twins and who were just born, and these 3 kids were also tested. So we need to be effective. We need to talk to those people to inform them. It's not that because they have the mutation that they're going to have cancer, but they have to be informed that there are strategies. There is the protocol, the Toronto protocol, and this is an amazing tool for the patients. And once they know they have the mutation, they'll be able to choose how they are going to be followed, and they have the best way of being followed with the protocol. So I'm going to switch gears, and I'm going to talk about the prevalence of Li-Fraumeni syndrome. So back when I started working with Li-Fraumeni over 15 years ago, there were very few cases around the world. We used to say 208, maybe a little more, but that was really a very rare syndrome at that time. In 2003, there was a paper published by Lalou et al. That estimated a prevalence of 1 in every 5,000, but that wasn't a population estimation. In 2007, we were able to find these 8 individuals within 11 individuals who were found to have a germline mutation to carry the R37H, and this was one of the first indications of the high prevalence of this mutant in Brazil. In 2008, we had a first study that evaluated the prevalence of this mutation in southern Brazil, and we had the indication that 1 in every 300,000 individuals in southern Brazil are carriers. And then 2009, we had another study that estimated at 1 in 2,000. And in 2013, again, specifically in Brazil, we had this very large study conducted by St. Jude and the guys back in Curitiba, who evaluated 170,000 newborns. And they found a prevalence of 1 in every 270 individuals. That's a huge number. So, our question was, what is the real prevalence of Li-Fraumeni in the general population? We don't know that. So in August last year, I came by this article with 60,000 individuals who were exome sequenced. And they did an amazing thing. They opened their database to anyone who wanted to look at it. So what we did was to check at this database, and we saw that there were some individuals who had cancer who were part of it. So we just withdrew this information, and we kept it in mind. And we started looking at their database. It's free. Anyone can enter it online. We put it here, TP53, and we came across several variants that still needed to be analyzed. So this is the information of 60,000 individuals, probably without cancer by the time they were recruited. Most of them were adults, even after the age of 50, if we include most of them. And several variants were found among these individuals. The other database that we came across was the FLOSSIes, Fabulous Women Over 70s. So Mary Claire King did this amazing group of ladies over 70 years old who never developed cancer. And she opened also their exomes for anyone to look at them. So we did the same thing, TP53, and we came across 118 variants. But the major challenge we have now as scientists is how to define what these variants really mean. Are they pathogenic or aren't they pathogenic? So Kelvin, who is a PhD student under Sharon Savage's and my supervision at the NIH, he conducted the study to estimate the prevalence of potentially pathogenic germline mutations in the general population. So we use the ESAC database, the FLOSSIes database, but also an in-house control group. We use this pipeline, which is a way of selecting the variants to define within all those variants that we found in the databases. And we were able then to define these variants as pathogenic, likely pathogenic, possibly pathogenic, likely benign, or variants of unknown significance. And the numbers were quite amazing. So within the general population, we had 1 in every 1,700 individuals in the population who were found to have a pathogenic germline mutation in TP53. That's not what's expected. We thought it would be smaller, a very, very reduced number. And that's 1 in less than 2,000 individuals. If we considered pathogenic and likely pathogenic, 1 in every 500, which is even greater. We tried to analyze each one of these variants, and most of them fell within this DNA binding domain, where we find in our Li-Fraumeni Syndrome patients as well. So we have here, for instance, the R175H mutation. So many people talked about it. We have mice models on it. We know it's a very highly penetrant mutation. Also for the R282W, also a highly penetrant mutation. We placed this in this graph to see, we know that the lifetime penetrance of these mutations reaches over 90%. So usually individuals who carry a germline mutation in those genes, they will develop a cancer. And why those individuals that we found probably didn't have a cancer? We don't know. So there is a possibility in our study that there is an overestimation. We know that there is a situation that probably we're going to have Jeff Weitzel talk to us a little bit later on. Since this population was mostly of individuals of an older age, this may be something that we call a false positive. This could be due to clonal hematopoiesis. It's an alteration that is not really in the germline, it's just in the blood. But also it could be underestimated, because with this technique, we didn't look at insertions, deletions that account to around 10% of all alterations we see in germline patients, synonymous variants. We have the T125T, which is a mutant we see in our patients. And also, we still have the possibility of having excluded all those who had cancer in their childhood and early adulthood as well. We do have an amazing tool that is coming up soon, thanks to Sharon Plon's efforts, which is the ClinGen effort, which will make our lives easier to classify those variants, and this is not yet available. So our take-home message, does this mean that 1 in every 488 individuals have Li-Fraumeni syndrome in the general population? The answer is no, but we have to think. We know that the prevalence is higher than expected. We've seen the numbers, but the penetrance is lower than estimated. We know that there are key roles that probably may play a role. We've heard this morning Louis Strong presenting the MDM2. We know there is the intron 3 polymorphism. We know that there is a strong immune effect that may be related as well. environmental factors. We're going to hear about Sharon Savage talk about a study we are conducting on hormone and other effects like breastfeeding that may change the risk of our patients. So what is going on with these patients? We need to learn that soon. And also, this is an important point. People just want to get tested nowadays. The panels are cheap. And genetic testing should always be indicated only to individuals who had cancer or a family history of cancer. You cannot do just in the general population a genetic testing. It needs to be well indicated, so it's not for anyone. And having a pathogenic or likely pathogenic germline variant in TP53 does not mean you have Li-Fraumeni syndrome. This is a change of paradigm. Before, whenever we found a germline mutation, we said, that's Li-Fraumeni syndrome. We started the protocol, and we just screened those people. If someone comes to you with this mutation, you really have to watch out. This is not a person that needs screening. We don't know what to do yet. But this is probably someone who's not a Li-Fraumeni patient, who may be someone in the general population who will never develop cancer or will develop a cancer at a later age, and maybe not within the Li-Fraumeni spectrum. So we just confirmed our data in the NOMA database that was more recently published, and we found very similar numbers. And you can go to Kelvin's poster just to confirm that. It's poster 17. I really recommend it. And I just want to mention this life-changing experience that I was able to participate. I even brought my son with me, and that was last August. And that's when the question came about the oral contraceptives and what about breastfeeding, how this would change the risk of those adolescents. They came with this question to me, and that's why we started doing the paper that it's about to be submitted now. And I just would like to finish with the work we've been doing with those families in Brazil. That is something that started already a few years ago. We have annual meetings. That was 2016. We had Sharon Savage, who came to meet the families with us. That was last year, the 5th annual meeting we had in 2017. We're happy to have Jen Perry, who came, and Holly Fraumeni. You're both here. And we're hosting another meeting this year in May. It's our annual meeting, and I hope to see many of our patients there. So there are many people I would like to thank for all the work we've been conducting. So Kelvin is doing all the work with the variants. Sharon Savage, who is our branch chief at the NIH. Pierre Reynaud, who is really the center of it all. That's where everything started. And Patricia Prola, of course, who has been fundamental to all the studies. And all the Li-Fraumeni team. We have amazing nurses and counselors working with us that are here today. And I really would like to thank them all.
Maria Isabel, very nice presentation. Yes.
Yes, Tom.
I'm confused about one thing, and that is your statement that maybe the number is an overestimate because of clonal hematopoiesis. As best I understand that, mainly from Ross Levine's papers and some others, you wouldn't get up to 50% P53 reads at all. You're talking about 4% of the blood having P53 mutant reads, and that they are all, in fact, in the myeloid compartment, and people have elevated myeloid numbers, precursors. So I don't think the blood would ever get up to 50% P53 reads. So that's why I was surprised to hear you sort of worry about the overestimation.
Yeah, I think this is one of the possibilities. We had to raise this question because now whenever very frequently, we're receiving even results from clinic laboratories where they ask for fibroblasts from our patients to confirm TP53 germline mutations due to clonal hematopoiesis. So this is a concern we all have when we're working with the clinic. It's not to detect the germline mutation in a patient who doesn't have it, who had just a phenocopy.
Did I see another question? Oh, gosh, I don't know where to go. Way up top.
Some of the people in the room also had, we had a paper last year, sorry, trying to come up.
Oh, it's blinking. Did someone shut theirs off?
We had a paper last year as part of a group, Simplexo, Jeff and Judy and Kara.
You should be on
And
now.
We saw about 1 in 1,500 people in the exact database had Li-Fraumeni syndrome. So what that shows is not that you're right or we're wrong or we're right. It just shows the complexity of calling the variants and trying to sort out, even looking at literally the same data. We looked at 26,000 from the non-Finnish European set. You looked at the entire set, but it probably wouldn't change that much. But it just shows the challenges of trying to nail down what is even a mutation when you're looking at similar data sets.
Yeah, I agree with you. The only thing I don't agree is that I wouldn't say 1 in 1,500 have Li-Fraumeni syndrome in the exact database.
Right, yeah.
I would say 1 in 1,500 have a germline pathogenic or likely pathogenic germline mutation that may or may not be Li-Fraumeni syndrome.
Okay. I'm going to take one more question, and then I'm afraid we'll have to finish up afterwards because we've already run a bit over.
So I have a question about the penetrance. So have you done this exercise with other known heritable syndromes? I mean, that's really the amazing thing, that you would have these that we can molecularly look at, and they really do affect P53 function. How about other sort of known heritable syndromes where we know the pathogenic mutation? Have you looked in these databases and done penetrance estimates?
Yes, there are several studies being conducted now. In our group at DCEG at the NIH, we have a publication that came out before ours, I guess, on DICER1 mutations. And we also found an extremely high number of DICER1 germline mutations that were not expected at all to be found in the general population. They have pleuropulmonary blastomas at an early age, and you just didn't have people in these cohorts with these alterations. Yeah.
It's great for the modifier feedback.
Yeah,
definitely.
that's it. Yeah.
Definitely. So thank you, Maria Isabel.